Imagine going to the doctor with like a sore mouth and finding out that a broken sharp tooth is putting you at the exact same risk for aggressive oral cancer as a lifetime of chain smoking.
Yeah, it sounds completely wild, but it is absolutely a reality.
Right, so today you are stepping into the shoes of a medical detective. We're opening a dense, highly technical stack of clinical notes, both handwritten and typed.
Right, and this stack is essentially it's the master roadmap for diagnosing, staging, and surgically treating a threat in one of the most vital, complex battlegrounds in the entire human body, the oral cavity.
And it's an incredibly high-stakes environment, right? Because the oral cavity is tied to our breathing, our speech, nutrition.
Exactly. Fundamentally, it's tied to our identity. And the notes we're dissecting today in this deep dive focus primarily on squamous cell carcinoma, or SCC, which actually accounts for over 90% of all oral cancer cases.
Wow, over 90%.
Yeah, and what's fascinating about this documentation is just the sheer scale of the response it outlines. I mean, it reveals this profound story about how the medical field categorizes a cellular rebellion, how they measure its progress, literally millimeter by millimeter.
And then how they orchestrate this massive, multidisciplinary counterattack. Okay, let's unpack this, starting with the very first clinical encounter.
Right, the intake form.
Yeah, what immediately caught my eye was this patient intake form in the notes. It's completely bilingual, written in both Urdu and English.
Yeah.
And it really grounds the entire document.
It does. It reminds you that you aren't just looking at abstract pathology in a textbook.
Right. This is a tool designed to gather clues from a real human being sitting in a clinic chair, just trying to articulate what's going wrong in their mouth. And the questions they ask are ruthlessly specific.
Oh, highly specific.
Yeah, they don't just ask about generic pain. They're looking for mechanical disruptions. Like they ask, does the pain radiate to the ear, or is there a foul smell or discharge? Are there loose teeth?
And those questions, they are strategically isolating the tumor's behavior, its local invasion. So pain radiating to the ear, for instance, that isn't just a general symptom.
A red flag, right?
A massive red flag for paraneural invasion. The tumor is likely irritating the auriculotemporal nerve, or the glosopharyngeal nerve.
Wait, so it's sending referred pain all the way up to the ear?
Exactly. And then the foul smell, that points directly to tissue necrosis. The tumor is actually outgrowing its own blood supply.
Oh, wow. So it's dying.
Right. The center of it is actively dying and decaying right there in the oral cavity.
That is horrifying. And the loose teeth question.
That suggests the malignant cells have completely bypassed the soft tissue. They're actively eroding the alveolar bone of the mandible or the maxilla.
Jeez. Which honestly brings me to the differential diagnosis list, the causes and risk factors, specifically the section labeled addictions.
Yes, the addictions list.
Right, because it lists things you'd fully expect to see causing mutations,
Right.
pan, tobacco, smoking, spirits. But then right next to those chemical carcinogens, it lists a sharp tooth.
Yeah, a sharp tooth.
I have to push back on this classification a bit.
Yeah.
How does a purely mechanical issue, like a jagged bicuspid, end up on the exact same danger list as a lifetime of inhaling toxic smoke?
I mean, it seems counterintuitive, right? Until you look at the mechanism of chronic irritation. We're so conditioned to think of cancer as this purely chemical or radiological phenomenon, mutagens directly damaging DNA.
Right, like radiation or tar.
Exactly. But physical and mechanical trauma operates on a different but equally dangerous pathway. Think about it. If a fractured sharp tooth is constantly scraping the lateral border of your tongue, day in and day out, every single time you speak, swallow, or chew, you are destroying that mucosal layer.
So the cells are just forced into this perpetual state of emergency repair.
Right. They're dividing constantly to heal a wound that literally never gets a chance to close.
Wow, so it just induces this hyperproliferative state.
Precisely. And every single time a cell divides, it has to copy its DNA. And there is a statistical risk of a replication error, a genetic typo, basically.
But normally our immune system catches those typos, right?
Normally, yes. The immune system or the cell's own proofreading mechanisms catch the typo and destroy the cell. But if you force those cells to divide thousands of times more than they naturally should.
Just to keep up with the physical scraping of the tooth.
Exactly. The probability of a malignant typo slipping past those checkpoints just skyrockets. That is why the notes group mechanical trauma right alongside chemical carcinogens. It's all about chronic, unrelenting stress forcing a cellular error.
That completely reframes the whole concept of risk for me. But the notes also detail how clinicians narrow down their suspects, right? Like before they even touch a scalpel.
Yeah, the differential diagnosis groups, they break the possibilities down to inflammatory granulomatous, which includes systemic infections like tuberculosis and syphilis, and then tumors.
But they use this brilliant visual shortcut based entirely on the physical topography of the ulcer's borders. It's almost like reading the architectural signature of the disease.
The visual morphology of an ulcer's margin is incredibly telling. The notes specifically contrast 4 different presentations.
Right, so if you're looking at a diabetic ulcer, the margin looks punched out. If it's a basal cell carcinoma, or BCC, the edge is rolled.
Yep.
Tuberculosis leaves an undermined margin. But our primary target today, squamous cell carcinoma, presents with an averted margin, meaning it's actively pushing out and folding over itself.
Right, it folds outward.
So what is mechanically happening in the tissue to create these vastly different borders?
It all comes down to the underlying pathophysiology of the specific disease. So a diabetic ulcer looks punched out because it's a vascular issue.
Meaning blood flow.
Exactly.
Yeah.
The microvasculature is compromised, blood flow stops, and a localized cylinder of tissue simply dies and drops away. It leaves this steep, clean cliff face.
Oh, I see. And tuberculosis.
TB is an infectious granulomatous process. It destroys the underlying connective tissue faster than the surface mucosa, so it creates that undermined overhang.
So the foundation collapses before the roof does.
That's a perfect way to put it, exactly. But an averted margin in SCC, that tells you that you're dealing with a wildly aggressive proliferative mass.
Because it's growing so fast.
Right. The cancer cells are multiplying so rapidly and so uncontrollably that they just run out of room. The tissue literally piles up, expands outward, and rolls back over the normal adjacent mucosa.
Wow, so just by recognizing that outward folding averted architecture, a skilled clinician knows immediately they're likely dealing with an aggressive malignancy, not an infection or a vascular deficit.
Exactly. It's a huge clue. But visual cues only get you so far, To really confirm the enemy and understand its battle plan, the notes transition from gross anatomy to a terrifyingly precise microscopic timeline.
The cellular rebellion.
Yes. It maps out the exact genomic instability that turns a healthy mucosal cell into an invasive killer. And it's not just a single switch that flips, it's a staircase of compounding genetic failures.
A cascade of very specific mutational events. The notes detail this progression, starting from normal mucosa to hyperplasia, and that's driven by a genetic alteration in 9p/p16.
Right, the P16 mutation.
I picture this entire process like a factory's quality control system systematically collapsing. At first, with that P16 mutation, it's like the factory's speed regulator breaks.
That's a great analogy.
The assembly line starts running way too fast. That's the hyperplasia. They're churning out way too many cells, but if you look closely at the workers, they still look relatively normal.
But then the notes indicate a progression to dysplasia, right? Flagged by mutations at 3p/FHIT and 17p/p53.
Yeah, and that P53 mutation is the catastrophic turning point, because the P53 gene codes for a protein that acts as the ultimate tumor suppressor. It's basically the primary factory inspector.
Exactly. If a cell's DNA is damaged, P53 halts the cell cycle to allow for repair. Or, it triggers apoptosis programmed cell death if the damage is unfixable.
So once you lose 17p/p53, the factory inspector is dead.
The inspector is gone. The assembly line is still running at hyperspeed from the earlier P16 mutation, but now damaged, deformed products are being allowed to stay in line.
Which leads directly into carcinoma in situ, marked by 11q/cyclin D1 mutations.
Right.
At this point, the entire factory floor is packed with rogue, defective machines operating in hyperdrive. But they're still technically in situ, like they haven't broken through the factory doors yet.
Not yet. But the final step on the notes timeline is invasive carcinoma. That's the moment the mutated cells physically breach the basement membrane and just spill out into the surrounding town.
So to figure out exactly where a patient is on that mutational staircase, you need to extract the cells and look at them. The notes detail several biopsy tools, but the distinction between them is really critical. Let's talk about those tools, because the notes list an FNAC, which uses a tiny 23 or 25 gauge needle, but then they also mandate an FNAD, which utilizes a much thicker 16 to 18 gauge needle.
Right, there's a big difference in size there.
Yeah, I mean, a 23 gauge needle is tiny, like what you'd use for a standard vaccine. An 18 gauge is practically a pipe. It's what they use to draw blood donations. If the goal is just to capture microscopic cells, why are we using such a massive gauge difference? Don't both needles just use a vacuum to suck up the rogue factory workers?
Well, they do use a vacuum, but what they capture structure is fundamentally different. FNAC stands for fine needle aspiration cytology. It uses that tiny thin needle to aspirate a liquid suspension of individual loose cells.
Okay.
You smear those cells on a slide, and a pathologist can look at them and say, yes, these individual cells have hyperchromatic nuclei, they're dysplastic, but you have absolutely no context.
Oh, so you just have a handful of rogue workers who you have no idea how they were organized inside the building.
Precisely. You don't know if they were in situ or if they had actually breached the basement membrane, because the thin needle just pulled them out of their environment.
And the thicker needle.
An FNAB fine needle aspiration biopsy uses that larger 18-gauge core needle to punch out an intact solid cylinder of tissue.
Wow, okay.
You aren't just getting cytology, you're getting histopathology. You capture the actual architectural structure of the tissue. So under the microscope, you can literally see the basement membrane and observe whether the malignant cells have invaded past it.
That makes so much sense.
Yeah.
The notes are also incredibly rigid regarding actual scalpel biopsies. They specify using an 11-blade scalpel to take an elliptical wedge of a tumor, ensuring you capture both the lesion and adjacent normal tissue for comparison.
Yeah, there's a strict rule there.
Right. They enforce this bolded rule. Never perform a wedge biopsy on a small tumor under 1 centimeter. For those, an excisional biopsy removing the entire lesion at once is considered ideal. Why not just take a tiny sample first to be sure?
Because taking a wedge out of a tiny millimeter scale lesion introduces massive surgical artifacts. If you cut into a 6mm tumor, you trigger a huge inflammatory response.
Oh, so the tissue reacts.
Violently, the tissue swells, necrosis sets in around the cut, and scar tissue begins to form almost immediately. If that biopsy comes back positive for SCC, the surgeon has to go back in a week later to remove the
Margins are completely destroyed.
Exactly. They won't be able to distinguish between the original tumor border and the inflammation from the first biopsy. So if it's small enough, you just take the whole thing out with clean margins on the very first try.
Okay, so once the pathology confirms invasive SCC, the clinical team has to gauge the true scale of the threat. The notes rely heavily on the TNM staging system, tumor node metastasis.
Right.
And the survival statistics documented here are brutal. If you catch an oral tumor early, at T1 or T2 stages with a clinically negative neck, the patient has an 80% survival rate.
Which is pretty good.
But the moment those cells migrate into the lymphatic system, becoming N positive, that survival rate is cut in half to 40%. Distant metastasis and positive drops it to a grim 20%.
Because the oral cavity is a highly vascularized environment with massive lymphatic drainage pathways. Once a tumor breaches those superficial layers, it has immediate access to a superhighway system that leads directly into the cervical lymph nodes in the neck.
Here's where it gets really interesting though. The notes explicitly separate two diagnostic measurements that intuitively sound like they should mean the exact same thing: tumor thickness and depth of invasion, or DOI.
Yeah.
Now, if a surgeon is looking at a 5mm lump, it's 5mm thick. Why does the oncology community split hairs over these two terms?
It is arguably the most vital distinction in this entire clinical document. Tumor thickness is an absolute gross measurement. A pathologist takes a ruler and measures from the highest mucosal surface of the tumor down to its deepest point.
So it tells you the total physical volume of the mass.
Exactly. But depth of invasion, DOI, is a relative measurement. It is measured exclusively from the theoretical reconstruction of the adjacent healthy basement membrane down to the deepest point of tumor penetration.
Okay, so if we go back to our factory analogy, the basement membrane is the ground level of the town.
Yes. Imagine a tumor that exhibits an exophytic growth pattern, meaning it grows outward into the open space of the oral cavity, kind of like a large mushroom.
Okay, picturing a mushroom.
That tumor might have a massive tumor thickness of, say, 12mm. But if it is entirely sitting on the surface and hasn't actually dug down into the ground below the healthy tissue line, its depth of invasion is 0.
That fundamentally changes how you view the threat. A tumor could be a massive, terrifying-looking lump in the mouth, but not actually be deeply invasive.
Right. Conversely, and also could be completely flat on the surface, almost invisible, but be digging a devastating trench deep into the underlying muscle.
Oh, wow. And that DOI measurement dictates the surgical aggression, right?
Absolutely, because it directly correlates with the tumor's proximity to blood vessels and lymphatics. The notes put a terrifying precise number on this correlation.
Yeah, I saw this. If a patient's DOI is less than 5mm, their risk of occult metastasis, meaning cancer cells, have already traveled to the lymph nodes, but are too microscopic to show up on a P or CT scan, is about 16%.
But the notes state that if the DOI exceeds 10mm, the risk of hidden occult metastasis jumps to an astonishing 46%.
Nearly half of those patients already have cancer in their neck, even if their scans are completely clean. That is insane.
It is, and that is why they split hairs over DOI versus thickness. If a tumor breaches that depth threshold, the surgical plan radically changes.
How so?
The surgeon cannot just resect the oral tumor anymore. They are forced to perform an elective neck dissection. They have to proactively strip out the cervical lymph nodes because the statistical probability of invisible cancer hiding there is simply too high to ignore.
Which brings us to the physical reality of the operating room. Preparing for these surgical strikes involves some incredible techniques. To ensure they get every last microscopic cell, the notes detail pre-op tissue staining using a wild cocktail of chemicals.
Yeah, it sounds like a chemistry lab.
Toluidine blue, Congo red, indocyanine green, and iodine. They're literally painting the inside of the patient's mouth to map the borders of the disease.
It's a required step because under the harsh bright lights of an operating room, severe dysplasia and normal, slightly inflamed mucosa can look identical to the naked eye. The chemistry of these dyes exploits the biology of the tumor.
So how does toluidine blue work?
Toluidine blue is acidophilic. It strongly binds to acidic tissue components, primarily DNA and RNA. Since squamous cell carcinoma cells have massive hyperchromatic nuclei packed with excess genetic material from constantly dividing.
Oh, because of the broken speed regulator.
Exactly. They literally drink up the blue dye while normal tissue barely absorbs it.
And iodine works on the exact opposite principle, right?
Yeah.
Iodine stains glycogen, which is abundant in normal, healthy oral mucosa.
Right.
So the healthy tissue turns dark brown, but the malignant cells, which have depleted their glycogen stores to fuel their rapid growth, don't stain at all. The tumor reveals itself as a blank, unstained island. It's literally a real-time chemical map for the surgeon's scalpel.
But even with those chemical maps, achieving negative margins, ensuring no cancer cells are left behind, is incredibly difficult.
Yeah, I noticed a heavily emphasized, highly critical section in the notes titled Cons of Frozen Section. Now, for anyone unfamiliar, frozen section is a technique where the surgeon cuts out a piece of the margin during the operation, freezes it instantly, and a pathologist looks at it under a microscope while the patient is literally still open and under anesthesia.
Right.
On paper, that sounds like the ultimate foolproof safety net. You check your work in real time. Why do these notes absolutely roast the frozen section method?
Because the clinical reality is plagued with variables. The notes highlight that while it seems like a safety net, frozen sections have an inability to reliably prevent positive final margins.
Wow, really?
Yeah. The physical act of flash freezing the tissue introduces severe artifacts. When you freeze a cell rapidly, ice crystals form.
Oh, because of the water inside the cells.
Exactly. Cell membranes distort, they burst, or they shrink. A pathologist looking at a frozen slide is looking at warped architecture. It is vastly inferior to a standard permanent biopsy slide that takes days to chemically fix in formalin and embed in paraffin wax.
So the frozen section might give the surgeon a false negative. The pathologist looks at the warped frozen cell, says looks clear, the surgeon closes the patient up, and then 5 days later the permanent slide comes back and reveals there was actually invasive carcinoma left behind at the margin.
And that leads to the psychological risk the notes warn about: over-reliance. If a surgical team leans too heavily on frozen sections, it can result in the undertreatment of the tumor. They might take a more conservative margin to spare tissue, believing the frozen section will catch any mistakes.
But taking a wider margin isn't just a simple choice. The notes force you to confront the devastating physical cost of cutting wider in the oral cavity. They explicitly reference the Andy Gump deformity.
It's a horrific outcome.
It's a jarring, almost cartoonish name, but the anatomical reality is devastating. This occurs when a tumor has invaded the anterior arch of the mandible, the very front of the jawbone, and the surgeon has to resect it entirely.
Resecting the anterior mandibular arch is one of the most debilitating outcomes in head and neck oncology. That specific piece of bone isn't just structural. It is the critical anchor point for the suprahyoid musculature.
What muscles are those?
The digastric, geniohyoid, and genioglossus muscles all attached there. Those are the muscles that control the tongue, the floor of the mouth, and your ability to swallow.
The notes state this results in a total loss of oral competence. Without those anchor points, the tongue falls back, swallowing becomes nearly impossible, and patients suffer from severe, uncontrollable drooling.
Yeah. The cosmetic and functional impact alters a person's humanity. It's a brutal razor's edge for the surgeon. Cut wide enough to ensure you don't leave microscopic cancer behind, but conserve every possible millimeter to prevent condemning the patient to an Andy Gump deformity.
And because the surgical intervention is so fraught and the risk of microscopic residual disease is so high, the protocol dictates that for advanced tumors, T3 and T4 stage of surgery is really only the first phase.
Right, we move into the adjuvant therapies.
Exactly. Port, postoperative radiotherapy, and CCRT, which adds chemotherapy into the mix. The goal is to sterilize the surgical bed and eradicate any invisible straggling cells.
So what does this all mean for you sitting there listening?
It's a long road. Imagine you've just survived a massive, life-altering jaw resection. You are prepping for your port radiation. The notes mandate a seemingly bizarre checklist item, a full dental assessment, and a mandatory removal of septic tooth. Why, right after surviving cancer surgery, is pulling a slightly infected bicuspid a medical emergency?
Because radiation to the head and neck is indiscriminate, and its effects on the skeletal system are permanent. Radiation therapy induces obliterative endarteritis.
Okay, what does that mean?
It literally scars and chokes off the tiny microscopic blood vessels that supply oxygen and nutrients to the mandible. The jawbone loses its capacity to heal.
Oh, so if you leave a questionable tooth in place, blast the jaw with radiation, and a year later that tooth develops an abscess and needs to be extracted.
The extraction socket will simply never heal. The irradiated, vascularly compromised bone becomes exposed to the bacteria in the mouth, leading to osteoradionecrosis. The bone literally dies and rots away in the patient's mouth. It is a catastrophic complication. That is why any tooth with even a hint of decay must be preemptively extracted while the bone still has a functional blood supply before the radiation begins.
It is a total scorched earth protocol. And the notes don't gloss over the grueling reality of what everyday life looks like during this recovery. They break down the nutritional pathways. If a patient is expected to eventually eat by mouth, they will rely on an NG tube, an esogastric tube, for up to 4 weeks, just to allow the complex surgical flaps and oral grafts time to integrate without movement.
And if the resection was so massive that they are classified as delayed NPO, meaning they will take nothing by mouth for more than a month, the protocol shifts to a surgically placed PEG tube, delivering liquid nutrition directly through the abdominal wall into the stomach. The fight to simply maintain caloric intake while enduring radiation is a marathon.
It's just staggering to look back at the scope of these clinical notes. We started with a bilingual intake form asking about ear pain and bad breath, and we followed the path all the way down into the microscopic laws of P53 tumor suppressors.
Yeah, it's incredible.
We measured depth of invasion down to the millimeter to predict hidden lymph node metastasis. We painted tissues with acidophilic dyes to guide the scalpel, and we grappled with the devastating anatomical realities of mandibular resections and irradiated jawbones. Treating oral cavity cancer is not just cutting out a lump. It is a meticulously coordinated, multidisciplinary war.
It truly is. And yet, even after all of that intervention, the biological reality of the disease presents an ongoing threat. I want to leave you with a deeply unsettling clinical concept buried in the margins of these notes.
Okay.
We established that over 90% of SEC cases are linked to smoking and tobacco, but the notes state that 10% of those successfully treated patients will go on to develop a completely independent second primary tumor in the head and neck.
Wait, not a recurrence of the original cancer, but a brand new genetically distinct malignancy.
Exactly. It's driven by a concept known as field cancerization. The entire mucosal lining of the mouth, throat, and lungs has been bathed in the exact same toxic carcinogenic smog for decades.
Oh, man.
The original tumor was just the first cell cluster to cross the finish line into invasive carcinoma. The rest of the tissue in that field already has the 9p/p16 mutations. It already has the p53 damage. The entire ecosystem is a ticking clock of genomic instability.
The soil itself is permanently altered. If the journey to cure just one of these tumors requires this intense level of surgical and radiological warfare, the implications of field cancerization are staggering. It is definitely something for you to ponder the next time you think about the incredible yet profoundly fragile ecosystem of the human body. An MRI might give you a clean binary answer for a torn ligament, but when you enter the microscopic battleground of cellular rebellion, well, the detective work never truly stops.